Hey everyone, it's Matt here from Free Associations. We've got a great episode coming up for you, but before we get into it, I wanted to make a quick correction to something that we talk about. So you'll hear that in segment 2, we talk about the new rule that the NIH is putting in place to redefine clinical trials. And it seems that in the time between the period at which we tape this and now the time at which we release it, there may have been a change in the decision to implement this rule. I'm going off of a paper that a website that I'm reading on the Association for Psychological Sciences website, in which they say the U.S. Congress has directed the NIH to delay enforcement of a new policy that would reclassify basic research involving humans as clinical trials. So I don't know for sure, but just be aware of that when you hear our conversation. And now on to the show. Welcome to Free Associations for the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who thinks that the latest medical study is as complicated to understand as reading James Joyce. I'm Matt Fox, Professor of Epidemiology and Global Health, and I am here with Don Thea and Chris Gill from the Department of Global Health.
Howdy, Matt.
Hey, Matt.
And we are here in the Boston University Godley studio. So before we get started, we do want to take a second to remind you about the Population Health Exchange, which is Boston University School of Public Health's resource hub for lifelong learning. Find out more at www.pophealthex.org, where you'll find this podcast, as well as many other population health learning programs and tools. A reminder, just if you can, go ahead and give us a rating on iTunes. That'll help other people find us, and we'd really appreciate it. Now, on to the show.
Unless it's a bad rating, in which case you really should not.
Obviously. So today in our first segment, which is our Journal Club segment, we are going to take on a study that asks whether treatment for back, knee, and hip pain as treated with opioids is better than treatment with non-opioids. In the second part of the podcast, which is our deep dive, we will talk about changes that the National Institutes of Health has made to the definition of a clinical trial, and we'll talk about clinical trial registries in general. And then in our third segment, which is our amazing and amusing, we'll get into some things that have us snickering in the hallways and things that just made us laugh until we couldn't continue to do the show anymore. So let's get into it. So for segment 1, before I do, I want to say that we've received a bunch of listener feedback, some suggestions for some topics. We want to respond to as many of those as we possibly can, but there's only so many shows. So
we love fan mail.
We love the fan mail. Keep it coming, but we probably won't be able to get to all of your suggestions, but we will definitely try. So in segment 1, we're going to take on an article that looks at whether opioids are better than non-opioids for the treatment of chronic back, knee, and hip pain. The study was published in JAMA. The first author was Aaron Krebs of the Center for Chronic Disease Outcome Research at the Minneapolis Veterans Affairs Healthcare System. And the study is titled Effect of Opioid versus Non-Opioid Medications on Pain-Related Function in Patients with Chronic Back Pain or Hip or Knee Osteoarthritis Pain, the SPACE Randomized Clinical Trial. So here are some of the headlines. The jury's in. Opioids are not better than other medications for chronic pain, says NBC News. Opioids no more effective than other pain medications, says U.S. News and World Report. For all their risks, opioids had no pain-relieving advantage in a year-long clinical trial, says the LA Times, and NPR says opioids don't beat other medications for chronic pain. Vox, I thought this was new. Vox says, finally proof opioids are no better than other medications for some chronic pain, which I thought was a little bit more nuanced than the others. So Don, let me start with you. Can you give us the overview on what this study was about, what they did, and what they found?
Sure. Bear with me. It's somewhat of a complex study. It's going to take me a little bit to get through, but just in terms of background, for really quite a number of years, opioid therapy has become the standard of care for chronic pain, despite the lack of really good randomized controlled trials and evidence that support that it's better than non-opioids. Observational studies have found that treatment of long-term opioid therapy is associated with poor pain outcomes, greater functional impairment, and lower return to work rates. Those are observational studies, not what they did here. It's a huge problem. Obviously, there's lots of death and disability associated with it. Apparently, 500,000 deaths have occurred since the year 2000, and every year more people die of opioids than in traffic accidents. So what these authors try to do is try to determine if opioids are better for at pain relief, chronic pain relief associated with the three conditions that Matt mentioned, which is low back pain, knee pain, or hip pain, in as standardized a way as possible. Their hypothesis was that opioids compared with non-opioid medications would lead to better pain-related function and better pain intensity, i.e. less pain intensity, or more pain relief, and have a more beneficial effect on adverse effects. The method that they employed was what they call a pragmatic RCT, a pragmatic randomized controlled trial. And I think probably the best way to consider this is it's really halfway between an efficacy and an effectiveness trial, in that what they try to do is they set it up in a very real world situation and in a clinic setting, and they set it up in such a way that there is a fair degree of flexibility in terms of how these patients are treated within their assignment allocation.
Can I stop you there? So how would this I mean, I think of a pragmatic trial as actually being an effectiveness trial, in that you're sort of really trying to do things in real world conditions.
Well, again, the complexity of the intervention that they devised here, I think, is maybe a little bit more than we want to get into in detail, but they structured it in such a way that the individual treating clinician had a lot of flexibility in terms of the various choices of medications within the opioid or non-opioid categories. So it wasn't a head-to-head comparison of morphine versus non-steroidal anti-inflammatories, in which case it would be very hard to do a study like that because there would be a lot of adverse effects, or there would be dropout, or it just would be hard to implement it, and the generalizability would be relatively limited. So it's I think a relatively new concept, this pragmatic RCT, but they made great effort to try to make it as flexible as possible. So, as I said, they compared the use of opioid versus non-opioid medications for 12 months on those three conditions. The inclusion criteria were that people had to have moderate or great back, hip, or knee pain despite prior use of analgesics, and that pain was every day for about 6 months, and it was 5 or more on a 3-item pain intensity. So really pretty bad pain. And that it interfered with the enjoyment of life and general activity. They excluded people who were on long-term opioid therapy or had contraindications to all the drug classes, such as active substance abuse disorder or particular sensitivity to some of the non-opioid medications. And conditions that could also interfere with outcome assessment, like life expectancy less than 12 months or severe depression. Those were the patients that were excluded. The population, they conducted the study in 62 VA primary care clinics in Minneapolis, and they went through the electronic health records in these primary care facilities to identify people who had this 6-month history of back, hip, or knee pain, and those are the people that were screened into the study. They randomized, they stratified by the primary pain diagnosis. So they segregated out people according to those 3 pain diagnosis categories.
And that being hip, knee, and back, right?
And back, right.
Yeah, got it.
And the medication assignment, once they were randomized, was known to the treating physician and was known to the patients. This is not a blinded study.
Not a blinded study.
But it was not known to the study assessors who did the final evaluation. So the prescribing strategy was complex. So for each category, for the opioid category and for the non-opioid category, they had sort of 3 levels of intensity. And this is what I mean in terms of it being complex, and gave the treating physician the ability to be able to escalate the level of analgesic care for the particular person, because things change over time. I won't go into what the particular drugs were because I don't think it's really that important. The follow-up was monthly initially, and then if they remained stable, they were followed every 1 to 3 months. The adherence was self-report, and they also assessed the refill prescription records from state state databases in terms of pharmacy records. The outcomes were pain-related function, which was assessed by a pain inventory interference scale, pain intensity, and they determined what was a minimal clinically important difference a priori as their outcome. And they also assessed adverse effects by using a 19-item checklist of medication-related symptoms for either the non-opioids or for the opioids. Secondary outcomes were, there were 10 scales.
They were a ton.
They went overboard, I think, on that. But 10 or more scales of function or quality of life. Adverse events they determined via new hospitalizations, ED visits, or falls. They also looked at opioid misuse, which they defined as using the opioids in the opioid arm in a manner other than prescribed, such as MD shopping for additional prescriptions or diversion of the opioids, substance use disorder, or death. And the statistical analysis, I think, was basically pretty straightforward. They did power calculation that they needed 115 to complete therapy, and based on that, they determined that they needed to enroll 265 patients, which they did, and they ended up randomizing 240 because 25 withdrew prior to randomization. The follow-up was pretty remarkable, I thought. 98% follow-up
For 12 months.
At 12 months.
Yeah, that's really good.
That was pretty amazing. The bottom line was that they're really, when they assessed those outcomes that I just mentioned at 12 months, both groups improved. But there was no real difference when you did a head-to-head comparison of the opioid and the non-opioid group. And the improvement that both groups enjoyed was defined as greater than a 30% improvement in the scales as compared to baseline. Most patients in the opioid group did not escalate to a higher intensity of medication, which is a good thing. The pain intensity was better in the non-opioid group. It wasn't different than the other group, but it was better. But it was better by a very small amount, and it was less than what they a priori decided was a clinically significant difference. There were more medication-related symptoms over 12 months in the opioid group as compared to the other group. And there was no difference in adverse outcomes or misuse measures, though they were underpowered really to be able to make that assessment. So that's sort of where we are.
And so overall, so if this pans out as a good study, this would be good news in that regardless of how you interpret it, would mean less of a need for use of opioids, or you could also say that opioids and other analgesics are just as good, and you could use either depending on what your preference was. And if you had concerns over issues with opioids, you could swap out, use a different set of medications. Chris, what's your take though on the quality of this study?
Yeah, so it was I mean, on the one hand, I thought it was very useful that they attempted sort of to create this clinical trial protocol that was very applicable to sort of a pain management paradigm in clinical practice. So, like, for example, if you were randomized to the opiate arm, there was this 3-tiered sort of step up in terms of intensity of therapy. Like at the beginning, you were given a prescription for immediate release morphine or immediately release oxycodone. And then the reason behind that is that it quickly controls your pain, but it also leaves your system relatively quickly. And so the theory is that this would be less prone to abuse and to leading to addiction. And if that didn't work, then they went up to the long-acting forms of these drugs. And if that didn't work, then they stepped up to, I think it was a transdermal fentanyl patch, which would be like, all day long being exposed to opiates. And on the non-opiate side, they started with Tylenol or ibuprofen or other non-steroidal anti-inflammatories. And if that didn't work, they moved up to adding sort of adjunctive pain therapies like amitriptyline or gabapentin, which are believed to sort of modulate pain pathways. And if that didn't work, and also the use of topical lidocaine and capsaicin creams, like for the affected area. And if that also did not work, then they moved up to tramadol, which is it's an analgesic that has quasi-opiate characteristics, but is not actually an opiate. So of all the non-opiates, it's considered to be the one that is most prone to abuse, but it is not technically an opiate. And so in that sense, I thought it was a very useful study, and I thought that the take-home message from this was generally positive, which is on, one, that very few of the patients who were randomized to the opiate arm got into trouble by using opiates. And so you could say, well, again, if opiates are managed in a very prescripted, careful, supervised way, the risk of leading to addiction need not be so great. And so that's an important point. And two,
which I think is an important point that gets missed in the headlines.
Yeah, I think that is an important point. But of course, the flip side to that is that unfortunately, the use of opiates in the real world is the wild, wild west. They're given them in very uncontrolled settings at extended doses without any supervision, and it leads to a lot of problems. So but the more interesting endpoint, which I think was what Don was showing, is that there was no advantage to the opiates for chronic pain management. And this is distinct from, if you have an infected tooth and you have an abscess, Tylenol is not going to do it for you.
Or a broken hip.
You probably need opiates. There's nothing that can control the pain in the short term. But that is a totally different question from whether long-term exposure to opiates is an effective way of managing chronic pain. And it turns out, in this case, it's really not. So I thought those were two really interesting take-home messages from this.
So, and I agree with those points, and it's a really interesting study. Does the sample size bother you guys? I mean, I agree with you.
It's a wee bit small.
It's 240 odd. You said 265. I think it was actually 240 because I think they didn't actually quite achieve it. Or anyway,
25 dropped out before
25. That was right. Sorry. I got it. You did say that. I mean. As always, I mean, are we gonna draw how strong a conclusion we're gonna draw from 120 patients per arm? But in particular, it's not just the 120 patients per arm that's an issue that is of concern to me. It's that if you actually look at their baseline tables, so the tables of what the characteristics of the two groups that got the opioids and that got the standard of care. Is it standard of care? Would you call that standard of care? Probably not.
Let's just call it because it's sort of a more
opioids and non-opioids.
Effective non-opioid pain management strategy.
Fair enough. Yeah. Opioids versus non-opioids, they're not perfectly comparable. There are some things there that are kind of concerning. So they were 20% versus 11% in terms of smoking. We're not talking about lung cancer as the outcome here. So does that matter? I have no idea. Difference in terms of illicit drug use, differences in terms of being of employment status, things that aren't absurd to find in a trial where you've only randomized 120 to each group, but still would raise some concerns. On the other hand, from what I can tell, at least in the way I puzzle it out, it seems to me that the group that if you were to adjust for these things, it would further favor the non-opioids. So it's not that I'm thinking here that opioids are actually better and it got missed because of the way the randomization was done. But the imbalances do sort of lead me to some questions. Don's raising his hand. Don, I'm officially calling on you.
So Matt, do you think that, pursuant to this point, do you think that therefore there should be a different sample size calculation in the setting of a trial like this, which is a pragmatic RCT, because you have less homogeneous arms. There's more variability in each arm, and therefore you're going to need more numbers to achieve precision because the variability will be great. And if so, do we change the rules for sample size calculations as a result? And has anybody really thought about that?
Well, I think there's a lot of work that's been done on sample size calculations for thinking about subgroup effects. And obviously, if you really do want to think about subsets of the population and whether or not these treatments are effective or one is more effective than the other within subsets of the population, you need to power your study very differently. To answer your question, I don't know. I mean, I'm not sure. Part of the reason why their sample size is smaller than you might expect is because they have a continuous outcome with what looks like to be not huge variability, and therefore the ability to detect differences in those in that scale is very different from what you would have if we were looking at proportions. proportion that achieved an outcome. Or you'd have to have really big differences in the proportion achieving the outcome to be able to detect them. So I don't know that you need a different sample size so much as my point is more, if you do a randomized trial that doesn't have a large sample size, the expectation of balance isn't there. And so the idea that we love randomized trials partly because they create the expectation that I have two equal populations in which to test my intervention, that doesn't necessarily hold true. It holds true in the expectation on average, but it doesn't hold true for one study. I would say I think you probably need another study. I think my second point here is about the nature of the pragmatic trial itself, though. I mean, pragmatic trials, as I understand them, is essentially trying to say, let's do this under more real-world conditions. Let's really try to understand what the impacts of the effectiveness is, which I would agree with your take, Don, that this is probably not a pure effectiveness study because, as Chris says, there was probably better management of pain medication in this study than there might be under usual care. There are some exclusion criteria in here that would suggest this is not sort of the general population. On the other hand, it wasn't excessive. But when you do these pragmatic trials, I do wonder whether the effects that you're observing are dependent on things that are not necessarily generalizable, like the quality of the treating physician in managing the pain, or something about the specific nature of the population in terms of their ability to access care, whatever it is. That we learn a lot from these pragmatic trials, but I'm not sure we necessarily get generalizable information that would say, in all cases, one of these drugs or sets of drugs is going to outperform the other. So
yeah, those are all really good points, Matt. I was curious for your both of your opinions about the blinding issue. Where for obvious reasons, they couldn't blind the participants to whether they were getting opiates versus Tylenol and capsaicin cream. I mean, it was clear what they were receiving. So this was not a double-blinded trial. This was a single-blinded trial, and the blinding was for the assessors, but not for the patients or the patient's doctors.
I'm not sure that matters.
I'm not sure
the assessors.
It does, but I'd like us to check that box and could there be some? I mean, they kind of addressed that in the table 1 by looking at the expectation for opiates versus non-opiates being more effective.
And which one did they?
They seemed about the same. So at least in terms of those who ended up randomized, there didn't seem to be a skew that the opioid people or one group over the other were more persuaded that the opioids were going to be better than the Tylenol NSAID arm. And that kind of gets at it, but it doesn't quite answer the question. And so could there be some bias from that? And if so, how could that affect us?
So it seems like you're sort of discounting a bit the expectation data, which is fair enough. So then hum a few more bars of that and tell me what you would think would be the expected impact of that, because my assumption is that people would think that the opioids are better for treating the pain and therefore would report lower pain scores at the end just because they knew they were getting the opioids, and we don't see that. We see the analgesic or the non-opioid arm doing better.
I agree. I mean, I think they probably addressed that issue, but it's still it bothered me, and I couldn't quite figure out whether this led me to be a little bit more skeptical about this at the end of it.
Yeah.
So,
Chris, are you talking about the pre-randomization perceptions of treatment groups?
Yeah, which were very well balanced in the two arms.
Yeah, they were.
They were. Yeah.
So you're saying that you don't believe that removed the bias?
Well, I don't know that it entirely answers the question because this is at the very beginning of the study, and then we have an entire year to go. And so, do those perceptions shift? We have no idea, and we're only looking at a single time point at the end, which is at the end of a year. Are they any better? And so, the skeptic could say, well, chronic pain doesn't mean intractable permanent pain.
Yeah.
Maybe that in both groups, their pain syndromes largely resolved or just got better by themselves, and it had nothing to do with either medication. And had they looked at 1 month increments, they might have seen a very different set of pain management efficacies as they were going along.
Well, so following on to that, I mean, what do you think the role of a regression to the mean is in this study? So in order to get into the study, Don, you said, and I guess I missed this because I didn't really understand. You're saying they had to have a pain score of 5 to get into the study?
I think it was 5 on a 3-point scale, 5 or above on a 3.
5 on a 3-point scale?
That's what they said.
3-item scale.
3-item scale. That's right.
So it was a 0 to 10 scale
right.
of
3-point
pain,
scale.
and 5 was the cut point.
On a scale from
Right.
1 to 10. Does this one go up to 11?
Yeah.
So if you had to get to a 5 to be in the study, let's say. So your pain is getting progressively worse. You know it's fluctuating around. You hit the 5 when it gets really bad, but that's just sort of your outlier event. You get into the study, and then things start to go back to normal for you, regardless of whether you were being treated or not. And so everyone's starting to get a little better, which is what you see. I mean, they go from 5 to 3, I think, in both arms. You know, some of this may just be just sort of regression
to the mean.
And I whether or not that would sort of mute any differences you might see, I don't really know.
Yeah,
but it does make me wonder.
I would have been much more persuaded, I guess, of or at least I think I would have a much better understanding of what the study interventions did if we'd seen more granular data in terms of pain scores over time. You know, for example, do we see that the opiate? You know, you could imagine that perhaps the opioid a randomized group at 1 month had much better pain scores than the Tylenol non-steroidals. We just don't know. But that but then those curves converge after 6 months. And so we could say at the 6 months or 12 months that there's no difference between these two pain management strategies. But is that really true? Because if you had like much better pain management at 1 month, that's not nothing.
Yeah.
That's significant, you know?
Yeah.
You know, so I think that they kind of skirted that question by saying that we're only looking at a chronic effect, which is fine, but it doesn't say that the two were necessarily equivalent during that entire duration of follow-up.
Can I get up one other issue, which is, so this was an intention to treat analysis, right? So intention to treat is essentially the standard way that we analyze superiority trials anyway, that we basically say in an intention to treat. Oh, and by the way, I should be clear, I'm not picking on this study. This is more a general comment about randomized trials, but I think it probably is more so in this one. Intention to treat says we're going to randomize you to one group and we're going to analyze you in that group regardless of whether or not you actually followed what we told you to follow. And these are over the non-opioid arm. You could get many of these medications over the counter, right? So there's no reason to think that people in the opioid arm might not also be taking the drugs that are in the non-opioid group.
Tier 1, you could get them over the counter.
Tier 1.
Tier 2
yeah,
and
you
3,
couldn't get all of them.
No.
But you could certainly get Tylenol and ibuprofen and Aleve and those things.
Right.
So you could be taking those as well. But we essentially say, no, I'm going to keep you in the arm to which you were randomized, even if I know maybe you stopped taking the opioids and you started taking the non-opioids. And we do that because the randomization creates the expectation of these balanced groups, and we maintain that over the idea that we have bias in which group you're actually, misclassification in which group you're actually in. We know that in the expectation that creates bias towards the null, so we diminish effects, and somehow we're okay with that. If I did an observational study and you knew that I had misclassified a lot of people on their exposure, would you be okay with that?
No, I wouldn't. That's exactly this issue about the 12-month duration. Like, there's a lot of devils in those details there that we don't get at all in this study. Like, what happened? You know, how much crossover was there? And they kind of sort of, dance around this by looking at the frequency of medications that were prescribed through the VA system.
Yep.
But Tylenol and NSAIDs are not medications that people get through the VA pharmacy. They just go to CVS like everyone else. So that would not be tracked. So we really don't know about the crossover. There's no robust data on this.
Yeah, no. If the misclassification were, as we say, non-differential, it didn't, wasn't unrelated to your outcome, then that should just bias towards no effect.
But it's not.
That would bias towards no effect. And we saw a slight benefit to the non-opioid arm. But your point, I think, is right here. It could be related to the outcome.
Because you can't go to CVS and say, I'd like 2 dozen Vicodin, please.
No.
You can't do that. You can go and get as many Tylenol as you want, but you can't go to CVS and just get Vicodin.
But that's different from whether or not it relates to whether or not you're misclassified. So you're saying one arm is more likely to be misclassified. That's different from whether your your probability of being misclassified is more likely depending on whether or not you had a positive or negative outcome.
So you're making the point that with non-differential misclassification, it's going to migrate to the null effect.
Yep.
But my point is that there's an obvious asymmetry in the misclassification. It doesn't go in both directions because the Tylenol people can't get access easily to opioids, whereas the opioids people have as much access to Tylenol as they want. And maybe that doesn't matter because Tylenol is a relatively weaker analgesic, but I don't know.
No. I don't think it matters mathematically. All that matters is that it's not related to the outcome. It doesn't matter that it's asymmetric. I mean, essentially, that's your equivalent of sensitivity and specificity. And as long as it's not related to the outcome, you're fine. But you could come up with a way that it
could it be related to the outcome?
Yeah, absolutely. Because the outcome is related to your baseline. Your outcome is pain at the end, which is related to pain at the beginning.
Right.
So yeah, absolutely. You could come up with a mechanism by which that is differential misclassification and could explain what's going on here. Absolutely.
So in the end, I guess
probably
I buy it, but I'm not totally sold.
Yeah. Don, what about you?
I think one other point that we didn't mention, but that relates to the generalizability is that this was done in a VA population, and only 13% of the subjects were women. And we all know that women have a much higher tolerance to pain because of childbirth that men never experience. But so it's generalizable to this particular population.
I don't know whether Chris is asking whether or not that's true.
True?
Yeah, I have no idea. I'm not a woman. I've never given birth.
I don't either, but I don't. Is it true?
It's my perception that most women have a higher tolerance to pain.
I have no idea. I have no idea.
No, neither do I.
All right. So any other last comments? I mean, I'm Don. I'm super impressed by all your insights, given that you actually read a completely different study when we were preparing for this. That we had our meeting this morning to get ready for this study, and Don kept making all these comments about the study that didn't seem to fit.
And you guys are looking
Didn't seem
completely
to fit with
quizzical.
what Chris and I were thinking. And
what is he saying?
we asked him which page number it was on, and we thought, that makes no sense. There is no page.
23, 32.
Yeah, he had read the wrong study.
Starting to twig.
Yeah.
Yep. Huh.
It was related. All right.
I like my study better, frankly.
Yeah, fair enough. Fine. All right, so let's move on then. Let's get into our second segment where we are going to at least start off talking about this new policy that the National Institutes of Health have come out with that has effectively redefined what's in and what's out when determining what's a clinical trial. And I probably going to get a blank look. Chris, can you tell us what the new policy is really all about?
Well, so in 1999, the government passed this law called the FDA Amendment Act, which, amongst many, many, many things, also addressed this problem of trial registration and publication bias. And the concern was that because we don't know the denominator of studies that have been launched, it is very hard then to have some appropriate tallying up of the effectiveness of clinical trials on a given topic because we don't know what the denominator is. So to solve that, they said that for all clinical trials that met certain criteria, you had to register the clinical trials on this national website called clinicaltrials.gov, and then subsequently, this law was amended, called the FDA Amendments Act, the FDAMA of
when
2000.
was that?
That was 2005-ish, 5-ish, I think. Anyway, in addition to requiring registration of trials on clinicaltrials.gov, they also required reporting of the results of those trials. So that we have
clinicaltrials.gov is a online registry where you have to register your trial before you've started it in order to prevent people from starting trials and then just never reporting them
or backfilling the data
because they don't like the results.
There's also a European equivalent.
Exactly.
Yeah.
So the registration part creates the denominator, and then the trying to persuade people to disclose their results on clinicaltrials.gov is a way of trying to get to the numerator so that you have a more complete understanding of how many studies on which topics were launched and what were the end results.
To try to address publication bias.
To try to address the issue of publication bias and selective publication based on outcomes of trials. So that's the big context behind which this new policy shift occurred. Now, that initial policy applied to clinical trials, and really the focus was on drug trials, and particularly industry-sponsored drug trials. But it has since generalized because I think the scientific community realized that this is not just a problem with pharma, but this is a problem with clinical research and maybe human subjects research, full stop.
Yep.
And so we've kind of like, it's concentric rings of regulatory oversight here, where initially it was really just drug trials that everyone was thinking about. Then it became all human subjects research, clinical research trials. And now the policy has expanded one further ring to say, we're going to also consider human subject studies that do not really relate necessarily to a medical intervention per se, but are done on humans, but also involve some sort of medical intervention, like a behavioral intervention, things that ordinarily
some sort of intervention has to exist.
Some sort of intervention has to exist, but would not have fallen into that paradigm of like drugs or devices or vaccines, which are like the obvious ones. And so that change created, I think, a ripple of anxiety through the behavioral science community about this, which is what we're going to discuss initially, right? So. Have I summarized that more or less?
Well, so
yeah, I think so.
So it seems that there are now 4 questions that have to be answered in order to figure out whether or not something falls under of this new definition of a clinical trial. So, does the study involve human participants? Are the participants prospectively assigned to an intervention? Is the study designed to evaluate the effect of an intervention on participants? And is the effect evaluated a health-related biomedical or behavioral outcome? If it meets all those criteria, then it is considered a trial, even whether or not you have ever randomized anyone, or as long as you've done something that is considered an intervention and relates to a health outcome, you are now doing a clinical trial. And this has implications, both because now it means it needs to be registered, which is probably in and of itself not a terrible thing, but it creates some logistical problems for things that didn't used to be. But it also has implications because some funding mechanisms don't allow clinical trials to be done under using that funding mechanism, and that's going to change things for people in the behavioral sciences, I think. Mm-hmm. So the example that we were talking about that I read online was the Washington Post was doing an article on this, and they talked about a researcher who was saying, they do studies where they'll give a person a box of Legos, and they'll say your job is to sort out the red, find all the red Legos, and they're trying to understand how does the human brain go. What's the process by which you go about trying to do this? Well, now that is considered an intervention if there is some sort of health related or behavioral outcome, which there's a behavioral outcome now, and you have asked somebody to do a task that's an intervention. This could potentially then become a trial that needs to be registered in a trial registry. That's a big change. Mm-hmm.
Yeah. So, for example, if after having them go through this sorting of red Legos and another group sorts blue Legos, if they then asked, how many of those patients felt anxious, that's a clinical trial. Yeah. I mean, it's a benign clinical trial, but that would essentially be, we're seeing, does red versus blue Legos lead to a change in anxiety? Absolutely, it's a clinical trial.
And it also ups the ethical oversight that comes when you label something a clinical trial. That it's not. I don't think it's necessarily required. I think IRBs have some leeway to determine what's a high risk and a low risk trial. But as soon as you say trial, that's what I think we would consider that study that we just described to be something that's really minimal risk. That's something you should be able to just sort of just do with a basic IRB review. But now that becomes a full board review that requires some higher level of scrutiny. Don is scrunching up his face like he just ate a lemon.
No,
so he does not.
I hate lemons.
I love lemons.
I do too.
How about limes?
No, I like limes.
All right. Yeah, cool.
Really?
I do.
Okay, we've gone down a rabbit hole here.
Grapefruits are in fact my favorite fruit.
Okay.
No, the reason I was scrunching was because
scrunching is a word.
The funding issue I think is a real issue, and if our colleagues in the behavioral sciences cannot get funded because they now have to define their proposal as a clinical trial, and the funder says no clinical trials. That's sort of a catch-22. I can't imagine that that's not going to be worked out in some form or fashion.
Sure.
I think that the burden of having to enter your study in the clinicaltrials.gov database, which we've all done because it's necessary in the kind of work that we do, is a burden, but it, in my opinion, is, a 25-minute burden. It is not huge. And I think that it is generally good in terms of transparency for having a unified database where all of this work is done, so that the second person that does the Lego study and does it a little bit differently, that the people who assess it, or if you're going to do a meta-analysis on Lego choosing, then you've got you've got a unified place to get the stuff.
And that statement about the burden not being too great just came from Don, nickel and dime Thea.
Yes.
Wow.
Yeah.
That is shocking.
Yes.
I will stipulate that uploading your data onto clinicaltrials.gov is a right nuisance. It's a very user-unfriendly website. It's very tricky to navigate.
You get errors all the
not that
time.
You get errors.
It is.
I find it very challenging to
Are we
figure
using
it
the same
out.
database?
We are.
I don't
I think we
so.
are.
Don just pawns this off on a research assistant.
No, I
you know,
don't.
The social science and behavioral literature has been under such scrutiny lately
Yeah.
for the lack of reproducibility.
We're going
of
to get into that on
psychological
a future
studies.
episode for sure, because
Yeah.
it's a great topic.
Because
I think that the other thing that if we're really going to fix the system, we're really going to go the distance and make sure that all the studies are adequately reposed in a database someplace
Reposed.
that we're able to access. I think we need to make sure that not only is the protocol put into the database, but that the results are put into the database.
it's
Because
really important.
a lot of times the protocols are put in because you can't get your data published until you've established that before you even enroll. But there's no stipulation that you have to include the data, the findings, the results.
Right.
And I think that is equally as important.
I totally agree.
So you see this as a good thing. You
Yeah,
see this,
I do.
this
I do.
I do. I think it's a step towards transparency and reproducibility.
Yeah. Standardization.
So hang on. So you could have accomplished the exact same thing then by simply requiring pre-registration of observational or non-clinical trials. You didn't have to redefine these studies as clinical trials in order to achieve the goals that you're getting at.
That is
Yeah, I
an
can see
important
it.
point.
Yeah, I
So
mean,
the-
I suppose. I mean, what you're kind of messing with the definition of clinical trials in order to be able to fit into an existing framework, which may not have been necessary. It's true.
There is a rigorous debate as to whether or not observational studies should have to be registered as well. And, some journals are coming down, very strongly on the side of no, the observational studies are different and we don't want to hamstring them in the same way. Others have said, yeah, they probably should be. And, we would do better. And I think that's actually the direction that some of the social sciences are actually going. And I'm not sure where we're going to end up on this. But so then answer this question. So was this a problem that needed to be solved?
I think it probably was. Yeah. I mean, I think if you look at here's an experiment that was done and it generates this. We talked about this with a specific trial recently, which we actually didn't do on the pod, but we talked about it on the pod, where there was this experiment that was high profile in a certain field and certainly drove the investigator's career, but then later could not be replicated.
Yeah.
And came under intense criticism and actually destroyed the individual's career. So you could say this is not just a regulatory burden. This is probably a way of protecting yourself because it stops you from being the one study that is perceived as being the kernel of truth in this, providing this seminal insight. When in fact it may have been that the same study was done a dozen times before and was never registered and was never published.
Yep.
And this was the one exception that showed this remarkable result. P is less than 0.05. Voila, it enters the literature. That's how it goes.
So you think this is a solution to a potential solution, a benefit in terms of the publication bias problem?
I think long term it protects us, and it's also the ethical thing to do.
Okay.
Yeah, I agree.
All right. So that was far more agreement in the end than I think that I had thought we were going to get to. So
Totally disagree.
I agree that you disagree. All right, so let's
disagree about that.
Let's move on to our final segment then, which is our amazing and amusing, where we want to highlight some of the things that, make us laugh until we can't stop laughing. and look at some of the weird and wacky things that inspire us. So, Chris, you're staring off into space. Do you want to?
Yeah, sure.
Do you want to go first?
We were talking about pain today, and so it triggered a memory of when I was a resident, particularly when I was an intern. This is my first year out of medical school, and I had a lot of patients in my primary medical clinic who had this condition called fibromyalgia, which is this chronic sort of debilitating pain syndrome, very poorly understood and really absent any particular effective treatments. And, we had a lot of seminars about this condition, and I basically knew that at that time, particularly, we didn't have anything much that we could do for it other than to recommend exercise and maybe antidepressants. And so when I saw my patients who had fibromyalgia, I would sort of like come in and sheepishly, I'm wearing my cruddy looking white coat covered with dubious stains, looking exhausted because I haven't slept in 48 hours, and looking like a total rube. And I would give my little spiel about fibromyalgia and our lack of effective treatments and blah, 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 blah. And my patients would look at me with utter skepticism and scorn and sometimes disgust. And I never helped anyone. And then there was Tom Cooney, who was our program director. And Tom had like this awesome like head of curly silver hair, and he wore these cool sunglasses most of the time. And he was athletic and had this great tan, and he had this deep sonorous voice. And his patients got so much better for their fibromyalgia than my patients.
In terms of pain?
In terms of pain. Like the Tom Cooney placebo effect was awesome.
Oh.
Right?
Okay.
Compared with the Dr. Gill, it was like, I'm like the anti-placebo. They look at me and they run in horror. They know that I got nothing. I've got nothing.
Is there an anti-placebo?
I think I was the anti-placebo.
The anti-placebo.
So I was like very early on impressed by the placebo effect. It was so clear to me that this was what. So, since then, there's been a lot of research about placebos, and some have even questioned whether is there in fact a placebo. And I think the doctors uniformly know that the placebo is their friend, whereas maybe the clinical trialists see the placebo effect as their enemy. Anyway, so I pulled up this study by Zhang, Z-H-A-N-G, and colleagues published in Annals of Rheumatic Disease from 2008. So this is going back a bit. And this was a meta-analysis of the placebo effect and its determinants in the setting of osteoarthritis. Now, what made this interesting is that there are a lot of, like with the study we did on antidepressants, there were a lot of placebo-controlled trials, but a lot of these studies also had a no intervention arm in addition to a placebo arm and the active arm. So they were able to do a meta-analysis around what is the placebo effect when you're comparing no treatment versus a placebo treatment. So nobody's getting nothing, right?
Nobody's getting nothing.
Nobody's getting nothing, but one group knows they're getting nothing. And
Wait,
the other group.
What? Nobody's getting nothing?
Nobody's getting nothing because it's nothing versus placebo, right?
So somebody's getting nothing.
So they're both getting nothing because the placebo is nothing in disguise, right? And yet, when you did the meta-analysis, you found that the people who got the placebos had spectacular responses to the placebo compared with no treatment, where they knew they were getting nothing.
When they knew they were getting a placebo.
Yes, no. So when the patients didn't know they were getting a placebo, they could have been getting the active control, the active drug, but they didn't know. But the patients who were getting nothing certainly knew they were getting nothing. And so you have sugar pill, which means possibly something. And the psychological tendency is for people to believe that they are getting the thing because already they feel better, versus I'm definitely not getting nothing and I'm grumpy and I'm feeling bad. And the effect size was around 0.5 on average. And it was
0.5 what?
It was an effect size. So it was a standardized effect size.
Okay.
Yeah. So it was, which, we would consider to be a moderate to strong effect of the placebo.
Wow.
So I thought it was a really clever way of looking at the data.
Very cool.
Yeah.
Don, what do you got for us?
So I have a study that was published in the BMJ, and the authors are Anders Barheim and Hagne Sandvik, both research fellows.
What month was this study published?
I don't have that here. Oh, December.
Oh.
And the title of the article is "The Effect of Ale, Garlic, and Soured Cream on the Appetite of Leeches."
Ale,
so garlic, and soured cream.
In other words, if I eat these things, will the leeches want to eat me?
No,
or we're feeding these things to the leeches?
No, what you do is you dip, a combination of things. You can dip the leeches in the ale.
Oh.
Or you can eat the garlic, or you can spread the sour cream on your arm. And what
Makes
they did,
sense.
they had 6 leeches were dipped briefly into one of 2 different types of beer, Guinness Stout or Hansa Bock, or in water, which acted as the control, before being placed on the forearm of one of us, HS. So that's
Wait a minute.
Hogne Sandvik.
So they stuck leeches on themselves?
So they dipped leeches in the beer, and then they put them on the forearm, and they measured the time between when they were applied to the forearm and when the leech bit.
Yeah, why?
So drunk leeches don't bite?
Apparently, no. Apparently, there is no difference in terms of their biting behavior based on the beer that
So
they're
you can
dipped
feed
in.
them, and it doesn't matter what kind of beer.
No, apparently not.
If you feed leeches beer.
Right.
Wow, that is revolutionary.
Yeah,
good to know.
They,
I mean,
they conducted this study in a what they term an intention to bite approach.
The practical implications of this are astounding.
They found no difference with respect to the beer. They found that they were inhibited, apparently, by sour cream being
Smeared on your
smeared
arm?
on your arm before you apply the leeches.
Wouldn't the lake water wash off the leech, the sour cream?
Yeah. If you were gonna
No,
turn this
separate,
into,
separate arm.
no, but if you were gonna turn
So
this
Into a practical advice for public health.
right, the practical advice would be if you're gonna go into a lake with leeches, smear yourself
with sour cream.
but then it's gonna wash
It's
off.
gonna wash off.
Right.
We
Right.
need
How does that
we
help
need
you?
like
Right,
a suntan.
Only Humphrey Bogart had known that in the Africa
You
Queen.
need a long-acting sour cream.
I was,
Yeah,
thinking,
but most-
I was thinking Stand By Me.
But most importantly, 2 leeches were placed on the forearm smeared with garlic, started to wriggle and crawl without assuming the sucking position. They were placed in water, but their condition deteriorated. When placed on a bare arm, they tried to initiate feeding, but did not manage to coordinate the process. Both leeches died 2.5 hours after exposure to garlic.
So
Just the smell of garlic?
Garlic, yeah. So if you smear garlic on your arm, you put the leech on, then the leech gets all disoriented, falls off, and dies.
So you should smear yourself with garlic
Correct.
before going into a leech and wow.
Why are you swimming in leech-infested ponds
That's
in
a
the first
really
place?
good
I wanna know.
question.
Okay, so is this the origin of the vampire and garlic?
Could be. Yeah, could
rumor?
be. Could be.
Probably true rumor.
Probably true. Yes, I am sure it is true. Yes, Chris, well done.
So they say
You have sussed it out.
ingested
To all
garlic.
our-
Ingested garlic has been reported to be lethal to some animals, but we believe that this to be the first study showing garlic to be lethal by skin absorption. Garlic has a definite force of attraction on leeches, but further research into this fatal attraction will require in-depth qualitative methods.
No, we're going to interview the leeches?
Yeah.
Okay.
Wow,
All right.
that's very handy.
That
to know.
is. Is it? Is it? It is. Yes.
I think we need to keep it at arm's length, frankly.
Oh, more research is needed.
Yeah.
All right. So then, for me, I got a question for you guys, because I've seen a lot of debate on this one. Who is the reviewer that gets you? Is it reviewer number 2 or reviewer number 3?
2
It's
seems
2.
to have my number.
2 is the one?
Oh,
Done?
it's definitely 1.
No, it's not 1. It's
Yeah.
always 2 or 3.
Yeah.
Why wouldn't it be number 1?
It's never
As
reviewer
soon as
number
they
1.
read it, they say this is like
No. It's either reviewer number 2 or reviewer number 3.
number 3.
Most people say it's reviewer number 2. I agree with you. For me, it's reviewer number 3. But most people say it's reviewer number
But who's leading the
2.
witness?
But here's one where they say, okay, reviewer number 3. But fine. So I'm a little late. I get it. But during Valentine's Day, did you guys see the hashtag going around, hashtag academic Valentines?
No.
No.
Okay. So people were posting academic Valentine, what do you call them, poems? Mm-hmm. I'm going to read a few of them to you. This one is from...
He's so literary.
I am. Okay, so I'm not even going to say who it's from because what does a Twitter handle tell you? But this one is, roses are red, lilies are blue. This poem was short, but reviewer number 3 required a number of modifications. So we had to cite many of his own poems, and also change the title of the poem, rephrase the last few rhymes, and replace violets by lilies. Hashtag academic Valentines. Okay, that was one.
That's good.
I'll give you another one. This one has a lot of brackets in it, but I'll just read it as is. Roses are assumed to be red unless otherwise stated. Violets are assumed to be blue unless otherwise stated. This statement on love is tenuous and unquantifiable. Please reframe as an arousal in the hypothesis. Roses are red, violets are blue. What colors are flowers? We can't say. N equals 2.
Oh, God.
Roses are red. Correlation isn't causation. If this gets retweeted, does it count as citation?
Oh, it should.
I like
It
that.
should. I just realized my pathway to promotion at last.
But you just said earlier your tweets get 0 retweets. That wasn't
so
early. That was
true.
last.
Aren't we assessed on the number of tweets?
I
in
think-
addition to the number of publications now at
I believe
Boston
we
University?
are now. So there you
doomed.
go.
I'm
You're
doomed.
Sorry. Well, so that's the end of our program. If you have any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at PopHealthyX, or you can tweet me at ProfMattFox, or you can tweet Chris at ID.
Not that it'll do you any good.
Or Don at DTheo1. Or you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Director of Lifelong Learning at BU School of Public Health, for supporting the podcast and basically for putting up with us. And Nick Guler for sound and editing. Thanks
Great
for joining
editing,
us.
man.
awesome editing, Nick.
Hope you enjoyed it, and we hope you download the next episode.